Good morning, everyone. This is Dr. Yasmeen Idrees. It's an honor to be a part of this platform with a passion for improving healthcare. Imagine fighting cancer while also struggling with a hidden battle: dependence on the very medications meant to ease your pain. This is a reality for some patients who develop opioid use disorder during the cancer journey. Opioids are often essential for controlling cancer-related pain, but their risks cannot be ignored. Today, we will explore further details about the disorder. Our topic for discussion is Beyond Relief: Updates on Opioid Use Disorder in Cancer Patients, a narrative review by experts. In the beginning, I would like to thank my team members for contributing towards this review. A bit about my biography. I am a medical graduate of Fatma Jinnah Medical University, Lahore, Pakistan. Following my graduation, I pursued postgraduate training in general internal medicine and completed MRCP UK as postgraduate qualification. I'm quite keen to explore research in the medical field and collaborated with Professor Patricia Tai from Canada for the same. Coming back to our topic, background. Cancer-related pain involves complex pathophysiology and can be debilitating, requiring long-term pain management. We all know opioids remain a cornerstone of cancer pain management due to their potent analgesic effect. However, opioid use disorder is recognized as a growing concern in cancer care. Opioid use disorder is a complex medical condition that leads to increased tolerance, physical dependence, psychological changes, and withdrawal symptoms if the drugs are discontinued. The disorder may precede a cancer diagnosis or emerge during and/or after treatment. Implications of opioid use disorder: they extend beyond the individual patient to the family and caregivers, healthcare system, and society at large. We may call it as a ripple effect. The purpose for this review was to assess the prevalence and scope of opioid use disorder in cancer care, identify challenges in cancer-related pain evaluation, and to seek a balanced, effective pain control with minimizing misuse. Methods used for this narrative review included a comprehensive literature review using databases such as PubMed, Medline, Scopus, ScienceDirect, and EBSCO. We also held Zoom meetings with our MDT, including medical and radiation oncologist, an internist, a pharmacist, and a nursing staff to prepare this narrative review. Our findings included prevalence and scope in the first place. According to a recent study in the US, 3% of cancer patients had opioid use disorder, while 9% reported pain medication misuse. Another study revealed 19% of the patients developed non-medical opioid use disorder within 8 weeks of initiation. The numbers are alarming. Pre-diagnosis opioid use and genetic predisposition may account for 50% of addiction risk, according to a study. Other reasons for the disorder can be increased survival rates of cancer patients due to advancements in treatments requiring long-term opioids. Mental health comorbidities such as anxiety, depression, post-traumatic stress disorders, they equally contribute to the disorder. Advanced cancer with chronic pain also requires prolonged opioid use, and it adds a burden to the opioid use disorder cases. We also found out the challenges to effective pain assessments in cancer care. Here is a tabulated form of them. The challenge could be subjectivity of pain. Pain could be felt differently by different patients depending upon the tolerance, threshold, and articulation. Communication barriers, such as fatigue, cognitive decline, and language barriers, they are important contributors to the poor pain assessment. We all know that cancer pain origin is complex, therefore multiple pain types that do exist in cancer patients, such as nociceptive, neuropathic, visceral, and treatment-related pain. Cancer pain can be fluctuating in nature, which can affect the assessment. Type and intensity, it may change over time with an incident, background pain, and a breakthrough pain. Inconsistent tool use is a very common contributor to the poor evaluation of cancer pain. Different scales are utilized by different physicians and the healthcare workers. They can lead to ineffective pain assessment. The common scales being used are numerical rating scale, visual analog scale, and BPI. Psychological factors such as anxiety and depression, they may influence the pain articulation. Patients may express less intensity of pain, while on the other hand, there could be people who experience more pain with the underlying disorders such as anxiety, depression, stress. Special populations like elderly, children, and cognitively impaired people, they are the ones in which it will be difficult to assess the pain properly. Healthcare system barriers like time constraints, poor documentation, and lack of training, they are very much contributors to the poor pain assessment. Navigating pain management guidelines. Studies reveal that WHO stepladder pain guidelines focus mainly on the non-cancer related pain, while they are commonly clinically practiced guidelines for cancer pain management as well. These guidelines, they are inadequate when it comes to the complex pathologies behind cancer pain. Hence, the need for proper guidelines for cancer patients' pain management. Considering the impacts of opioids on the patients, we found out, and we all already know, that they can lead to the impairment of bowel function, breathing, cognition, and quality of life. Behavioral and psychological changes leading to excessive cravings, ending up in addictions, they are another factor. Prolonged use is linked to immunosuppression and possibly increased cancer risk, and this finding needs more studies though. Findings revealed that balance between pain management and the use of opioids and risk factors for the opioid use disorders is crucial. Cancer pain related to disease and treatment impairing function and the quality of life cannot be underestimated. Undertreatment is another area to consider while prescribing analgesics safely. Hence, comprehensive pain evaluation and personalized prescription is vital. Conclusion. We discovered and suggested preventive strategies such as the first and the foremost being comprehensive pain evaluation, considering all those categories which can compromise pain assessment in cancer patients. Using proper consistent tools for the assessment of pain such as visual analog scales and numeric rating of pain on a scale that can help assess pain effectively. Analgesics tailored according to the individual needs of the patients and the type of the pain, they are very important. Using opioid risk assessment tool can reduce the burden of opioid use disorder. The fact which must not be neglected is the patient education and prescription monitoring. Further preventive strategies could be starting with the non-opioid therapy such as cognitive behavioral therapy, relaxation techniques, physiotherapy, acupuncture, and radiotherapy. antispasmodics, NSAIDs, neuroleptics, and immunotherapy. If prescribed according to the needs of the patients, they can help reduce the doses of opioids in cancer patients, hence reducing the opioid misuse as well as the opioid use disorder. Exploring newer options such as suzetrigine, which is a recently approved drug in the US in January 2025. Working towards the gene-targeted therapies is an also important area to consider. Key takeaways from today's presentation include comprehensive pain evaluation is crucial. Introduce pain as a fifth vital sign. It can help save patients and societies, along with healthcare systems which might crumble because of opioid use disorder in the developing nations. Early adoption of multimodal intervention is critical. I would like to acknowledge that members of International Oncology Corporate Research Group, they have been quite helpful while analyzing information and supporting throughout. I would like to wrap up saying, together toward better pain management. Thank you.